So, in the coming session, we have three interesting topics. Just I want to kindly request to the speakers, kindly adhere with time restrictions, be time conscious, so that we can finish it off in time, and also it will be a two-way discussion. We involve a discussion with the audience for 15 minutes. So kindly adhere with the time. And the first topic, I invite Dr. Parandaman sir. He is a retired professor of Keel Park Medical College. First, Dr. Pushpa is saying he is a retired person. He is not looking like that. He is still potentially, sir, okay. And his topic is regarding future therapies in diabetes. It is a very interesting topic. So already it is time. So you carry on with your topic, sir.
Thank you for a kind words, chairpersons, my examiner, teachers. Lakshman sir is my examiner. Yes, sir. And dear friends, at the outset, I'd like to thank the organizers for having given this wonderful opportunity to talk on the future therapies in diabetes. The future therapies in diabetes is evolving and emerging. There's a paradigm shift from multiple injections to weekly injections, and no cure for the type 1 diabetes to the cure for the type 1 diabetes. And a lot of things are there. I just discussed in two things. One, type 1 diabetes, and it is the treatment management plan is directed towards the immune cells and prevention of the possible reversal of type 1 diabetes, stem cell therapy, which is cure for type 1 diabetes. Emerging therapies in type 2 diabetes is a dual receptor and triple receptor agonist, tissue preferential insulins, and take-home messages. Just take a brief pathophysiology. The beta cells are killed by the autoimmune process. The major brunt is on the beta cell by the T cell, the T cell effector cell. As soon as the viral infection or environment factors affects the pancreas, this particular antigen is engulfed by antigen presenting cells, and this goes and present to the T lymphocytes, which peripancreatic T lymphocyte. That activates the T lymphocyte effector cell. The effector cells migrated to the pancreatic beta cell or islets, it destroys the beta cells. That is the autoimmune process starts. So usually when it is in adolescent age, and sometimes by the viral infection. And by the time they develop clinical type 1 diabetes, clinical disease, 85 to 90% of beta cells are already destroyed. So they, with the only 10% they will be living at the time of clinical presentation. So not only the T cell, that's a major impact, the B cell also kills by releasing the antibodies against the beta cells and well as the inside proteins. In addition, in type 2 diabetes, excess amylin secreted along with insulin that also damage the beta cell, but it's not, that is only for type 2 diabetes. We have stages in type 1 diabetes, stage 1, stage 2, stage 3. The stage 1, the detection of only antibodies. There is no rise in blood sugar, only antibodies. There are no clinical symptoms, no blood sugar rise. Stage 2, the presence of antibodies and the presence of raised blood sugar, but no symptoms. Stage 3, antibodies, raised sugar, and with the symptoms. So why the staging is important? The staging, because if you identify it in early stage, you can prevent it from developing to stage 3, that is a clinical disease. Or if you are at stage 3, you can try to reverse the disease. That is an idea of putting the stages. And this is a flow chart taken from the Diabetologia 2023. That's a treatment algorithm. So any treatment plan, we start with the local action. That is local action, the islets of pancreas, beta cells, then systemic effects, then compound effects. So the first effect is local. The beta cells are being destroyed and by the autoimmune process, so we can prevent the local damage by immunization, by oral insulin. Oral insulin is not to decrease the blood sugar. The oral insulin is allowed to sensitize the immune system not to destroy the beta cell. That's oral insulin. And also you have oral the peptides against GAT65 protein. And also we have the local effects of the pancreatitis, that is the GLP-1 analog, that it decreases the inflammation of around the beta cell, so that can be tried as a drug to prevent the damage at the local site. Not only that, that GLP-1 will increase the beta cell growth. The second thing is the systemic effect. The systemic effect done by the cytokines. The cytokines are IL-1, IL-6, TNF-alpha. In addition, there is anti-CD3. The CD3 antigen is the one which destroys. The T cell is the one which destroys the beta cell. So that you target these things, thereby preventing the damage, cytokine-mediated damage to beta cell. You can reverse it. And also we have both immunosuppression by the T cell, B cell suppression by the thymogenic, that is anti-thymogenic globulin, and CD20, that is suppress the immune system, thereby there is no damage to the pancreas. Fourthly, the organ damage can be prevented by metformin and SGLT inhibitors. Again, the other the group of drugs can be used. And lastly, the stem cell therapy. The stem cell therapy is the one which is evolving, and that's supposed to cure the type 1 diabetes. Yes. So vaccine. Vaccine, we give oral vaccine, that is insulin, as already alluded. It is supposed to sensitize the cell, immune system, and increase the tolerance of the beta cell to prevent the damage by the immune system. That's the thing. Not only the insulin, and also you give protein derived from the beta cell, that also can be tried, and also you can GAT65 protein can be given orally. It can improve the tolerance and prevent the destruction. Then we have the targeted therapies. What are targeted therapies? Because we know the pathophysiology, T cell, effector cell is the one which damages the beta cell, and that is the one causing this problem. So you try to block it, that is antibody to CD3 antigen, so that you can prevent the damage and reverse from damaging the beta cell, that beta cell function improves. That's one concept. The second concept is that is the redoxide interfering protein, which is being nicely done by the verapamil, commonly available drug verapamil, which is supposed to decrease the stress in the beta cell and stress in the islet cell around the pancreas. Thereby, it is used for the prevention of the diabetes progression. And also, we have the cytokine-mediated other drugs like anti-TNF-alpha and TL2, IL-1-2 receptors. That is, if you give IL-1 receptor, it improves the tolerance of the beta cell. However, the immune system is activated, antibodies comes, it won't get disturbed. So that can be done. So of course, there's a wonderful effect by the GLP-1 analog, especially type 1 diabetes concern, as anti-inflammatory and increase the cell growth in that thing. So the new molecule is called tepsilizumab. It prevents and delays the clinical disease, as I already alluded to. It is a monoclonal antibody against CD3, and that is supposed to target the T cell. And if you give this, it prevents the disease. So it can prevent from developing stage 1 to stage 2, from stage 1, stage 2 to stage 3, thereby no clinical disease. So we have these indications. We give one course of food drug, that is for 14 days. You want everyday infusion for 14 days. It improves the outcome by 2 years. There is no clinical symptoms development. That's a wonderful molecule, and only few side effects. There are other therapies to prevent and delays, like anti-thymogen antigen, this thymocyte globulin antibodies. This blocks both T1 and beta cell and T cell, both are being suppressed, so thereby the antibody mediated as well as direct killing also blocked by this thing. And also we have the cytokine T antigen specific T cell, that is called abatacept. This is the one which is supposed to directly suppress the effector T cell and allowing the other T cell not to disturb. So we have hydroxychloroquine, oral the drugs are also available for the newer drugs. So if you see the disease, identify the person, stage the disease, identify in stage 1, stage 2. So if they are in stage 1, stage 2, prevent it, developing stage 3. That means he is preventing from symptom. If you comes with the stage 3, reverse it by your molecule or what I told. So that's an idea. So GLP-1 analog is available as this multiple effects directly on the inflammation and increase in the immunogenicity, and all this particular effect is there. And we have got oral drug also. New molecules have come. Tirzepatide, it is having both dual. So you have got single, dual, and triple agonist. The dual agonist is a tirzepatide is a dual, and retatrutide is a triple drug. The triple agonist means GLP-1, GIP, and glucagon. The glucagon is the one, it increases the free fatty acid and metabolism, thereby decreasing the lipogenesis, that decrease the weight. So it is mainly used for the obesity with diabetes. And of course, these are two when a combination of the two molecules, anti-CD3 and the GLP-1 receptor agonist, is supposed to reverse type 1 diabetes from stage 2 to stage 1 and stage 1 to 0 stage. So that's a reversing molecule. And the future therapies also, the one thing is a combination therapy, not only GLP-1 with the anti-CD3, we also combine this anti-thymocyte globulin with the granulocyte colony stimulating factor, and immunoglobulins like the immunomodulators like IL-2 is supposed to increase the regulatory T cells, thereby immune destruction is prevented. And of course, we have the stem cell therapy, which is the most important one. Stem cell therapy is nothing but you are deriving the pluripotent cells, you derive the beta cell and by engineering, and that particular cell, that's very popular because when you have pancreatic transplantation for type 1 diabetes, the donors are less. Patients are plenty, but donors are less. So very difficult to find out a donor, and complications, surgery, all that there. So you derive the beta cell from the stem cells, and stem cells from the liver cell, brain cell, the skin or endothelial cell, any cells you can derive from pluripotent cell. So that is increasing the production of the B cell and injected into the patient. So that goes and increases this insulin secretion. That's a concept of the stem cell therapy that's coming up now. If it's successful, probably you can reverse the disease. And this is how this can be taken from the brain cell, liver cells, and bone tissue, bone marrow, all these things are there. It is engineered and is making the immature beta cell to the mature beta cell, and injection into the system. It goes and deposits in the areas, and that releases the insulin. That is the one is called reversal of diabetes. So that can be done with it easily. And other therapies we have, so artificial pancreas and smart insulin. We have smart insulins. Smart insulins, instead of putting injections every 4th hourly, 6th hourly, that you give smart insulin patches available, insulin watch available, insulin other modes of delivery is available. So instead of giving injections, you can deliver in different forms. That is there. Artificial pancreas is the one which is what that does, that is identify whatever we do, you does same way. So you identify the blood sugar level, you calculate the insulin and inject it, and also again it modulates according to your stress levels also. So that's the one beauty of this thing, and that's available. And therapy is addressing the complications like amylin inhibitors. Amylin inhibitors supposed to be the part is mainly for the type 2 diabetes, and that can be used pramlintide. Metformin is not found to be very much useful, and SGLT inhibitors. SGL inhibitors are very useful because it prevents absorption of sodium, the glucose in the GIT, and also it is in the kidney also prevents. But problem is one ketosis is prone, so you have to be careful with that. So other therapies, the activation of glucanase in case of type 2 diabetes is glucokinase receptor agonist activation that can be used, and inhibition of the 11A hydroxysteroid dehydrogenase 1, that is for type 2 diabetes, and G protein coupled receptors G40, that's another molecule is in the market, going to be released, and that is also very useful. You have got dual and triple agonists. And regarding the newer insulins, long-acting insulins, what we have this Icodec insulin, that is for 7 days of life, and once in a week you can give. And another new insulin is that Efcitron. Efcitron is a newer drug. It is given weekly once, but half-life is 17 days. Probably if you a fortnight, but it is studied for 17 days, but its half-life is 17 days, so it can be used for fortnight. So you need not give every 4th hourly injections. So that's the new things that are available. It is coming to the market. And combination therapies, again, this is for obesity and MASH. MASH is nothing but NASH. NASH is nothing but metabolic associated liver disease, steatohepatitis. So we have the dual molecule, combination of GLP-1 analog with the glucagon agonist. Glucagon agonist. Glucagon is the one which increases lipolysis. So lipolysis and decrease the blood fatty liver and decrease the obesity, and all this. The combination is very well used. Both combinations are very well used for the diabetes with obesity. And of course, the mode of delivery system, what we are only using injections And now we have inhaled insulin, nasal insulin, buccal insulin, oral insulin, ocular insulin, rectal insulin, transdermal insulin, and of course we have the nanotechnology using artificial insulins, and so many insulins are on the going to be there. Most importantly, the tissue preferential insulin. The tissue preferential insulin is the one you give insulin subcutaneously, it is absorbed, it is not functioning. It goes to the liver. In the liver sinusoids, the large area, it large molecule, it released there. So, even though it is injected, absorbed, not functional, only it goes to the liver, it acts. So, that's called tissue preference. So, only that particular area it acts. So, tissue preference insulin and also glucose sensitive insulin. This is called hepatopreferential insulin, and tissue glucose sensitive insulin. When you give a molecule, it acts only when glucose is high. It will not act when glucose is normal or low. So, how very specific. That is glucose sensitive insulin, that is also in the pipeline, and Inceptor. Inceptor is the one, is the insulin receptor blocker. See, most of the time we have type 2 diabetes insulin receptor, that is resistance. The insulin resistance not only due to hyperinsulinemia, there is something called new molecule called Inceptor. This is a molecule go and binds to the insulin receptor. When the insulin comes, it will not act because already blocked by the molecule, the protein. So, that Inceptor is now you reverse the Inceptor, you improve the insulin sensitivity. That's a new, very, very new thing. It's a really boon for a patient with insulin resistance. Of artificial intelligence, yes, we are using stem cell therapy, genomic therapy, and 3D bioprinting and pancreatic cells are being used. Yes, I am completing my talk, sir, shop, and take home messages. Better understanding of the pathophysiology, the beta cell suicide and beta cell homicide, there is a paradigm shift in management of diabetes from non-curable to the curable disease. There are innovative approaches preventing the immune-mediated destruction, targeted therapy, anti-CD3, anti-CD2, anti-CD20, and anti-thymosin globally with GLP-1 analog that prevents the disease, treat the disease, and reverse the disease. Stem cell therapy in combination with again other drugs, it reverses type 1 diabetes. The long-acting insulins, like innovations in the delivery system, is user-friendly for the patients. And tissue preferential insulin, Inceptor, is a real boon for the patient with the insulin resistance. Thank you very much for patience.
So thank you. Thank you, Parandaman sir, for a very crisp presentation and almost completing in time also. So he is on his way to an API meeting, and in another 5 minutes we can take some questions and audience discussion regarding this topic. Anyone want to add anything? Dr. Pannisalvam sir is my mentor. He is a role model for me. He is motivated me to come to this stage. Thank you very much, sir, for your help. So he has very well explained the newer researches both in type 1 and type 2 also. And regarding type 2 diabetes, I am seeing this topic in a different angle. The basic principle of newer research and newer invention is to invent a drug which acts at a different level other than beta cells, and to give beta cell rest and also to rejuvenate the beta cell. This is the basic principle of the newer researches. But I personally feel the best way and a natural way to do this thing is dietary, nutritional therapy, exercise, and by weight reduction, so that we can aim at remission in type 2 diabetes. This is quite possible, and our goal regarding treatment of diabetes has to change. We can achieve remission, and it is not possible to try this in all patients, but at least for well-educated patient, I am doing this for my doctor colleagues, fellow colleagues, because they have a good knowledge about diabetes, they adhere with the nutritional plan, and they can monitor themselves, and they have a good accessibility to the medical care. So it is the right time for us to reconsider and revisit our dietary recommendations and to aim at remission in type 2 diabetes. So, sir, you want to say something?
I think,
Thank you, sir, for your excellent presentation. I'm Dr. Nandita from Dr. A. Ramchandran's Diabetes.
I know.
Thank you for your excellent talk. Just 2 days ago, there was a publication from China in Nature where they have stem cell transplant that you had referred to, and a lady with around 50-year-old lady with type 1 diabetes with her own stem cell that they had implanted, and they claim that within about a couple of months, she's now free of insulin completely and cured of type 1 diabetes. They've done it in 3 patients, and this one lady is now so far cured. They say that the other 2 are also looking positive. My question, and to senior sir, Paneerselvam sir is also here, and to the chair. My question was, how do you view this from the Indian standpoint? They've done this in the Western world, and of course China is not too far, but how do you view this in a country like ours in the Indian standpoint, and what is the future in a country like India?
Yes, actually now, as of now, we are seeing type 1 diabetes in a lesser age, less than 18 years. So we start targeting those population now. Now we identify the risk factors, genetic risk factors, and the rapid growth. The rapid growth is one of the hormonal change which triggers. The viral infection, hepatitis B, cytomegalovirus, any non-specific virus, it triggers. So identify the individuals to high risk, especially less than 18 years, who are prone for type 1 diabetes as of now as autoimmune disorder. There are so many people with autoimmune disease occurring in elderly, that is different. But here, so you identify those individuals, risky people, and do the molecule, that is biomarkers, the antibody testing. If it is positive, that is stage 2. If blood sugar is elevated, again you do HbA1c, blood sugar elevated, antibody positive, no symptom, it is stage 2 type 1 diabetes, you target them. It is a question of, it is a high index of suspicion. It is not the clinical manifestation. We are going to pick up the disease before the clinical manifestation. So there is no question of history is helpful. Only identifying the genetic makeup and the other risk factors we have, probably that we can do. And community is difficult because it's a new area. Community is difficult.
I think we'll conclude here, sir, but very comprehensive. I was very happy and I learnt a lot, especially for the future therapies of type 1. Very interesting. Thank you for a wonderful talk.
Thank you.
So next I invite Dr. Priya Malini from Madras Medical College, and his topic for Priya Malini is regarding management of diabetes in elderly patients. I think the topic is tailor-made for her because she is a diabetologist come geriatrician. So, madam, you can carry on with your.
Thank you, chairpersons, and thank you, Scientific Committee, for the wonderful opportunity. The topic is going to be a more clinical one. I think it was a research topic by Sir Paneerselvam sir, wonderfully taken. So, I'm going to talk about the challenges in management of diabetes in elderly. So, why is this topic important in this forum is that, and is the burden high? Obviously, the prevalence of diabetes in elderly population is increasing because we have huge number of patients entering into the age group of above 60. So around 25 to 33% of prevalence is present in the elderly population with diabetes. So both diabetes and pre-diabetes is very, very common. And what is to be noted importantly is that there are a lot of comorbidities accompanying with this, with elderly patients. So a lot of high morbidity and mortality is there, and the risk of death is going to be very high when the age crosses 75 years. So the complications are going to be very, very high. The microvascular complications is going to be very, very high in this set of population. So we have a huge corners to address to in this elderly population. And the most important aspect of this topic is that we have a wide variety of extensive variability among this population. So taken to the clinical presentation, it's not the same. It's not the polys. They present with infections. They present with just a tiredness or a fall or hospital admission or during routine clinical investigation. So the clinical presentation is different, and we also have to address into the psychosocial situation, the environmental, the dwelling aspect, their social support. And one more thing, even if the patient is going to be very, very healthy without any medical disease or comorbidities, the higher frequency of acute illnesses which can put down their health at various points of time. So all these things is very, very important. So the multimorbidity, associated factors, as well as the functional aspect of the patient, as well as the cognitive aspect, all this has to be noted into before fixing up a treatment protocol for that individual elderly person. So setting up a treatment goal itself is the first important point when we actually address management of type 2 diabetes. And among the, so an appropriate assessment of all the other comorbidities and effectively managing them also prevents most of the complications. And one more important thing to be noted is you have to assess them, reassess them very frequently for both microvascular, macrovascular complications, as well as their functional status, as well as the cognitive status very frequently, and reset their goals every point of time when the patient is having any acute problem. And there are a lot of other factors, external factors, which influence the management of diabetic in elderly population when you take into the dwelling aspect itself. So it matters a lot. When the patient, an elderly patient is in the community setup, his way of management or the protocol given to manage his diabetes is a little different when they live in an assisted living setup or a nursing home setup. So for example, if you take them in a community, even if the patient is going to be highly functional, the intellectual status is going to be good, cognitive status is fine, and, but there's no caregiver support and so on. But still then your prescription should be very, very simple. You have to educate and re-educate them because there's going to be no support. And even if they are going to be medically stable, acute illnesses which can occur on and off can put them down. So those times they need some amount of guidance. So the scenario totally changes when they live in some assisted setup or a nursing home setup where they need a caregiver support for giving them the appropriate diet, timely diet, the food they want, as well as for the medications. So all these factors really impact and has a very huge impact on the management of diabetes in elderly population. So I'm going to talk about, discuss two cases here. 65-year-old Mr. X, he's a known diabetic past 25 years, hypertensive 18 years, and a CAD patient for 10 years, with recent history of right hip hemiarthroplasty following a fall 2 months back, and now he's walking with support. The patient attendance gives history of recurrent hospitalization due to heart failure for the past 2 years, and the present status, he has a very uncontrolled blood sugars. He's partially dependent, quite depressed because of his illness and with the intact cognitive status. Laboratory values are high blood sugars, lipids and BP is under normal. His current medication, you can see a list of them, with the sulfonylurea metformin, SGLT2 inhibitor, and DPP-4 metformin for diabetes control and antihypertensives, CAD drugs, along with that diuretics like furosemide, pantoprazole, and calcium. Now, the hurdles to overcome in this particular patient is that patient is definitely bombarded with drugs. So polypharmacy is the most important thing to be addressed in this particular patient. And you have to bring down a blood sugar, decent control without any hypoglycemia. The other risk in this particular patient is that he is partially dependent. He has a risk of fall and recurrent hospital admissions brought heart failure. So all these things has to be addressed as a whole while you manage this patient. So it is only not the glycemic target, it is other extra glycemic factors or the comorbidities which we have to focus in this particular patient. Coming to my second patient, this is a 75-year-old female, a known diabetic for past 20 years, hypertensive for 15 years, with recent history of cognitive decline, diagnosed with an Alzheimer's 5 years back, and she's on treatment. Patient attendance gives history of recurrent urinary frequency with bedwetting at times and refusal to feed and aggressiveness at times, and past 2 months she has 2 episodes of hypoglycemia. Current diabetic status is very stable with a very good control, and at present medications with the sulfonylurea metformin, DPP-4 combination, metostatin, telmisartan amlodipine for BP, and donepezil for Alzheimer's. So my main problems here we have to address is this patient is completely dependent on a caregiver for support. So decreased cognitive status, so the food, the medication, everything has to be provided by the caregiver, plus the urinary frequency that can lead to a lot of complications in diabetic and nutritional status. All factors depends upon the caregiver support. Patient is completely unaware of what is happening. So the main challenges in any diabetic elderly patient which we have to focus is, we have certain considerations. We have to look into the patient as an individual. Not only his diabetic status, his other comorbidities and other living conditions, everything has to be assessed before you set up a goal for that particular patient. And the main thing is being a decent glycemic control. You just have to avoid hyperglycemic crisis. avoid hypoglycemia. That is very, very important. And a choice of medication should be very, very ideal. So the facts about diabetes in elderly, we all know that as we age, there is going to be a decline, there's a change in glucose metabolism. So decline in beta cell function, increased insulin resistance, receptors are going to come down, and the response for the hepatic glucose output is also going to be very, very high, both fasting and postprandial levels. So reduced physical activity, and patient might have inappropriate diet and eating habits and other coexisting illness. So these 4 points are very, very ideal. And looking into the other aspect, you have to avoid polypharmacy. Patient might have other comorbids, so patient on n number of drugs. So polypharmacy has to be looked upon. And the nature of the patient as they grow old, there's a reduction in lean body mass, so sarcopenic obesity. We had a very good discussion by Dharmarajan sir yesterday. So that is a very important point to be noted in elderly patients. So focusing on that when we choose drugs is very, very ideal. And first and foremost, the cognitive and functional status of the individual and predicting the longevity. So patient is very healthy with no comorbidities, the lifespan is going to be higher. End of life stage, you can fix up targets according to that. So basic pathophysiology of aging leading to diabetes, we already discussed. We all know there's a decline in beta cell function with resistance and this downregulation of receptors. And the pharmacokinetic and pharmacodynamic changes of aging is also very well known to us. As we age, there's going to be decline in the renal and hepatic function. There's increased volume of distribution of drugs, especially the lipid-soluble drugs. So the concentration of drugs is going to increase. The half-life of drugs is going to increase. So you can have complications of hypoglycemia, and other physiological aging changes per se can interfere with the drug metabolism, especially very commonly the slower peristalsis, which we encounter in most of the patients and complication. And the geriatric syndromes, they do have a very huge impact in the management of diabetes in elderly. We all know the giants. So, for example, the polypharmacy, you have to look upon drug-drug interactions and side effects. And when patient is going to have a fall, a very injurious fall, leading to a fracture, there's going to be immobility. Once again, it's going to have a very high impact on diabetes control. Incontinence per se, because the risk of infection is going to be high. And the other way around, when patient has incontinence, he'll try to restrict fluid. There's going to be a lot of volume depletion, so dehydration and increased osmolality and even hyperglycemia can set in. And delirium, this can be precipitated with one episode of hyperglycemic crisis or a hypoglycemia. Vice versa, when patient is delirious, the routine medications during that period has to be altered. So all these goes hand in hand. All these syndromes and diabetes management goes hand in hand. Sarcopenia and frailty, you will have definitely altered drug metabolism and absorption, and cognitive decline and complete assistance for both food and drug is very, very important. So what are the ideal important steps when we try to manage a diabetic patient is that first, you individualize the treatment goal based on the functional, cognitive status and the comorbidities and the longevity. And prescribe the ideal treatment, choose the correct drug and the regimen. Choose medications very cleverly, one drug with multiple actions so that you can avoid your polypharmacy, and avoid over-treatment because one episode of hypoglycemia is going to be more hazardous than a hyperglycemic crisis. Regular screening for microvascular and macrovascular complications is very, very important. And regular reassessment of functional and cognitive status and goal changes is the ideal key point in management of any elderly type 2 diabetic. And diabetes education and re-education. This is very, very important, not only to the patient, but also to the caregivers and support persons who are available to take care of the patient, and management of other coexisting illnesses, bringing them to target to avoid complications. So the goal setting depends upon, various guidelines tells us the ADA and IDF. To make it very, very simpler, this is a simple thing we can follow. Have stringent goals of A1C reduction to 6.5 to 7.5% when the patient is very healthy and with the functional status, no comorbidities, shorter duration of diabetes and very high longevity. If the comorbidities are going to be very huge or geriatric syndromes, multiple geriatric syndromes are present, the functional and cognitive impairment is present, patients having a risk of hypoglycemia, shorter life expectancy, and polypharmacy falls and other geriatric syndromes, you can go for little flexible goals of 7.5 to 8.5. So you can also make it very simpler. You can go into the IDF goal. Functionally independent, you have a very simple goal of around 7 to 7.5. Functionally dependent, 7.5 to 8. And end of life care, you can go above. There's no goal settings. You have to just avoid symptomatic hyperglycemic crisis. And hypoglycemia, the elderly, the bitter truth is that first and foremost, if the patient is going to have a cognitive decline, he will fail to report the symptoms. That's most important. He will forget to report the symptoms. And duplication of medications are very, very common that leads to hypoglycemia. And hypoglycemic unawareness is once again very important thing to be addressed to, because they'll be unable to recognize and treat it by themselves. So, and most of the elderly, they try to over-treat themselves fearing hyperglycemia. And if they have hypoglycemic episodes, they'll try to skip doses, and that will alter their prescription by say. And one event, obviously we know that can precipitate a major macrovascular event like a cerebrovascular disease or a cardiovascular disease. And recurrent hypoglycemia, the quality of life is going to come down very badly. So coming to the treatment per se, lifestyle modifications, mainly in an elderly type 2 diabetic. So we know that diet and exercise plays 2 important role, but there are other factors which has to be addressed to in an elderly type 2 diabetic. Diet per se, it's totally depends, a lot of challenges, the availability, the nature of drug and so on. The first and most, try to avoid a overload of carbohydrate diet. A well-balanced diet with high protein and adequate protein, adequate fiber is very, very essential. Avoid fasting and feasting. Coming to exercises, individualize the treatment goal. That is very, very important. And just try to promote yoga and meditation, group exercises, online classes if the patient is good, functionally stable and cognitive stability is there. And if the patient has risk of falls, even that simple 5 to 10 minutes of walk 2 to 3 times a day will be very, very ideal for a patient to improve his mobility and improve his glycemic status, but definitely under guidance. And other important areas to be focused on is adequate sleep, because good sleep hygiene is going to bring down sugars, blood sugars, BP under control, and improve the quality of life. The social activities, promoting group activities and help them to, getting involved in social gatherings is very, very important, because it's going to de-stress them and improve their glycemic status as well. Immunization is one important topic which is ignored. Adult immunization, especially in elderly type 2 diabetic, is going to prevent a lot of acute infections and it's going to maintain a good health. Coming to the choice of hypoglycemic agents in elderly, the entire list is known to us. Metformin still becomes a first drug of choice, but choose the molecule depending on the EGFR status. Above 45, you can use it. 30 to 45, use with caution, but go with very low doses and extended release formulations. And caution is to be taken when patient has sarcopenia or GI side effects. Sulfonylurea, short-acting sulfonylureas are useful because the risk of hypoglycemia is going to be very, very high, and weight gain is also there. Thiazolidine diones still can be used with caution because the risk of hypoglycemia is very low, but the risk of fractures and volume overload status, especially in patients with CAD, you have to be very careful. DPP-4 inhibitors, very safe in elderly, no risk of hypoglycemia, but the GI side effects, decrease in gastric emptying with fullness and loss of appetite is commonly reported by elderly patients. Alpha-glucosidase 1 inhibitors, once again the GI intolerance is always there. The newer drugs, mainly the GLP-1 analogs, this is quite safe in patients, elderly diabetic patients, and with comorbidities. But one thing is, once again, the GI side effects, and main drawback is, except the oral semaglutide, others are going to be injectable, so training them is going to be very difficult. SGLT2 inhibitors can be used in elderly. When we choose the ideal patient, one important risk we have to keep in mind is hypertension and hyponatremia that can produce. And insulin and diabetes management in elderly patients. So we know that choosing the ideal patient, so assess them physically and the cognitive status before initiation. Start with very low doses. You have to monitor them adequately. Teach them education, re-education becomes very, very important. And what the ideal choice of insulin depends upon the patient as it. Patients having erratic eating habits, you go for rapid-acting insulins than short-acting insulins because you get in between hyperglycemias. Peakless analogs will be useful to maintain high hyperglycemic values. And usually the preferred regimen is premix insulins. But when it comes to premix insulins, the eating habits should be very, very important because you cannot monitor them daily because most of them take it a very early meal at night with very, very low quantities. So last 1 minute because there was an interruption between. So looking into the focus of these 2 cases, the first case we were talking about polypharmacy, risk of fall and other things. So this patient, when you look into the drug chart, you can see n number of anti-diabetic drugs are in there for the management. So this particular patient will be more beneficial if he is functionally and cognitively stable. You can just switch over to insulin and try to manage 1 or 2 oral hypoglycemic drug. In this particular patient, I would prefer to maintain the patient and with SGLT2 inhibitor because patient is already CAD with the cardiac failure patient and cut down a bit of sulfonylureas and if necessary the metformin also. Oh, and the risk regarding risk of falls is already there because, and when you're adding SGLT inhibitors, you try to cut down with the antihypertensives as needed. And good counseling and education of the patient as well as attender will be very beneficial for the patient, number one. And the second patient with a lot of cognitive decline, urinary incontinence, nutritional access, and caregiving support. Here, it's mainly education. And one more about the factor about this, the glycemic status. This patient was very strict control. HbA1c was around 7.3. You can just loosen down the control. You can have a loose glycemic control. You can make a goal up to 8 so that he doesn't have any hypoglycemia. And education and of the caregiver is more important here, giving support. So new technologies will definitely be useful when the patient is cognitively and functionally stable, especially the CGM monitors when the patient is on either insulin or OHAs, with alarm systems indicating hyperglycemic crisis or hypoglycemia. Even we do have type 1 elderlies, so hybrid closed loop systems are useful. Apps which will give us support systems which will help us to diet recall and give alarm systems are very, very useful in elderly patients when they are cognitively stable. And my last slide to summarize. The diabetes management in an elderly patient is going to be wholesome. You have to manage diabetes and other comorbidities together. You have to assess the patient individually in his functional status and cognitive status, set up goals, and try to reassess them as frequently, screen them frequently for microvascular and macrovascular complications, and treat them accordingly with simple regimens to be followed. Thank you.
So thank you, Dr. Priya Malini. Please stay there. Being a geriatric diabetologist, you know the pulse of an elderly patient than a physician diabetologist. Very nice talk. Now, anyone want to add anything on, or anyone want to ask anything regarding this topic? You can proceed.
You told about the sleep is very important in the elderly diabetes.
Yes, sir.
But it is also important in the young diabetes.
Yes, sir, definitely, sir. No, I just want to concentrate, like, it's not, lifestyle modification is not only diet and exercise. There are other factors which keeps everything under control.
The important limiting
So actually,
factor.
the pro-inflammatory, there is a study of sleep, sir. The inflammatory markers comes down when you have a sound sleep of 7 to 8 hours. So that article was published, long back, but there are a lot of recent researches in sleep also.
I think you can also add one more risk factor, that is the light. Recently in diabetology, there is a good article published where they have shown that if in the night you are exposed to intense light,
Yes,
you are prone to diabetes.
Yes.
So, the important limiting factor in treating an elderly patient is hypoglycemia. So, there is no need for a strict control in a geriatric patient in treating diabetes, because hypoglycemia risk is more, because most of them are poor eaters first, and they have some renal compromise. They have a visual disturbance. So sometimes they will take more insulin, and they have memory disturbances also. So they can take the drug twice. They forgot the thing. These are the common problems. And just a relaxed target of around 200, I think practically it's enough. 200 to 220 is enough to treat a elderly diabetic patient. And one thing I want to say regarding this glyphosins, you have to be very careful in choosing this drug in elderly patient, because they are more prone for hyponatremia. And another point is, they are most of the elderly patients have prostate. So the UTI, upper UTI, pyelonephritis are common in these patients. So these glyphosins can precipitate these UTIs in such patients. So anyone want to add anything?
Sir, which age in elderly, we are talking about the SGLT inhibitors in elderly.
I personally believe this SGLT inhibitors is the best drug in a obese patient. So any unstable patient, any patient with infection, or any patient who are prone for UTI, any patient with the lean patient, we have to be careful in using this.
One practical thing,
Yes, sir.
diabetes and elderly, we should look into benign prostatic hypertrophy.
Yes, sir.
See, when a symptom comes, urgency, frequency, it may be because of diabetic autonomic system problem, it may be because of infections, it may be because of BPH. Last, it may be because of some antidepressant drugs which a patient takes. So we have to balance this, and the BPH, when it is more in a male, early surgery will help. We cannot pull on with tamsulosin for a long time to get a total obstruction. So that is one added.
Yes, sir. So
Just to-
usually in geriatrics, what we say is whenever we are addressing any symptom, please do a drug recall. That is very, very important, what we call as brown bag technique. So ask the patient to bring all his drugs, whatever he's taking. He might be taking an anti-diabetic drug from us, or he might be taking an analgesic from an ortho person. OA&E is very, very common. A cardiac may have a prescription and a nephrologist can have a prescription. So the brown bag technique is very, very important. So that is what that will help us to actually eliminate most of the complications. So whenever a symptom arises, just see if it's due to a drug side effect. That is the first important teaching which we usually tell.
You know, just to add to that, because he mentioned about BPH in male patients, similarly, overactive bladder in female patients is generally overlooked. So use of, you know, proper anti-muscarinic agents and trying to assess their symptoms very important. Apart from BPH, even OAB in male as well as female.
Yes, sir. See, practically speaking, more of overactive bladder, we see a lot of stress incontinence and urge incontinence. So most of the time, it's going to be simple infections and simple pelvic floor exercises will help them very lot. Overactive bladder, yes, it is present, but the percentage of patients with overactive bladder is quite less when we assess them practically. We have a lot of specialty clinics. We have incontinence clinics also. So these parameters are very less. More of stress and urge incontinence is common.
And I think that slide was really nice, madam. I think that has summarized your talk. Person you have with a shorter duration of diabetes, longer life expectancy, less comorbid conditions or complication, you can aim for more stringent control, 6.5, irrespective of being elderly.
Yes.
But when life expectancy is, you know, short,
Yes.
more
See,
comorbid.
as we now see, sir, we have a lot of people in every forum where they cross 60 easily. So most of them, they don't want to be called as elderly at all. Okay, so that is why that is a cutoff point. In the Western population is 65, it is year 60. So we have a lot of young people who maybe we brand them as elderly. So when they
is
has to
individualized.
focus as adults, young adults.
It is individualized.
Yes,
Depending
individualized.
upon
That is
the...
what that mean.
Age is not a cutoff.
Yes, sir. Yes, sir.
It is just a number.
Yes.
Yes, it is individualized.
Fundamental principle of managing in elderly is to define the elderly.
What, madam?
What, madam?
What, madam?
Statins in elderly people with diabetes.
Strategies.
Statins.
Strategy is very simple.
No,
She
statins. She's
Statins.
asking statins. Yeah, ma'am, statins, we do have studies for use in primary prevention. Secondary prevention, obviously, when the patient crosses 60, most of them are, they have 2 or 3 comorbidities. So statins is useful. So it is useful in both primary and secondary prevention. When it comes to complication, yes, they do have a lot of, myositis and so on. But most of them are tolerant.
So,
age cutoff you said about elderly people. According to geriatric society, it is 80 plus, not a 60 or 70. In this form you take, all of the people you call...
so it is applicable for Western world.
Well, Western is 65, sir. India it is 60.
That is that. But here, because there's a lot of comorbidities we face, the younger diabetics, the people who get diabetes at the age of 20, 25, all these things. And now one more thing I want to add. A PSA should be checked after 60 years, sir, for what it matters. Apart, like the BPH, you can pick out this also,
Very good point, sir.
because these certain things which I thought I should share with you, sir.
Doctor, you want to say
Madam.
something?
If I could just add, excellent talk, madam. Thank you for that. And I think in terms of BMI and SGLT2 inhibitors, I was just again thinking out loud here again, wondering if it is more in terms of BMI that we should be looking at, or are we more wary about the euglycemic DKA in patients who are lean diabetics who are more beta cell deficient? So by definition, when we look at our population, when we say lean, as a population, our BMI is definitely a lot lower. So there are people with a lower BMI with more central adiposity and visceral adiposity who may benefit from an SGLT2 inhibitor because of the obvious reasons. So should we be looking more in terms of misdiagnosis or beta cell dysfunction of the type 1.5 patients who have insulin deficiency more than resistance, leaning more towards type 1 and 1.5 type 2, or not just pure type 2 diabetes, who were initiating an SGLT2, we are wary about the euglycemic DKA in terms of, instead of thinking of just labeling them as lean type 2. So I'm just wondering if it should be based on beta cell function rather than the BMI.
I personally think it should be based on beta cell function rather than BMI, sir,
Yes,
madam,
absolutely.
because sarcopenic obesity is very, very common, and we do have very, very simple measures to assess sarcopenia nowadays. So, I mean, I'm ruling out that the beta cell function should be the very ideal point in starting and any elderly with SGLT2 inhibitors. That is more important to avoid,
So thank you, Dr.
Thank
Priya Malli. Thank you for presentation. And next, I invite a smart guy from Madurai, Dr. Mahesh Babu, like Arvind Sami. So he's a chief consultant of Meenakshi Mission Hospital, Madurai, and he's my junior in UG, diploma, and also in MD General Medicine. And his topic is regarding mitochondria, the therapeutic target in diabetes. So, Mahesh, you carry on with the topic.
Yeah. Respected senior professors, respected chairpersons, friends and colleagues, good morning to all. At the outset, I'd like to thank the track organizers for giving me this opportunity. So the topic for discussion is mitochondria as a therapeutic target for diabetes. So for the next 10 to 15 minutes, please bear with me. I will be talking more on biochemistry and pharmacology and taking you back to your undergraduate days. So we all know that the core pathophysiology of type 2 diabetes is insulin resistance on one side and beta cell dysfunction on other side. So only these two are the core pathophysiologies of type 2 diabetes. Other factors are there like hepatic insulin resistance, SGLT2 dysfunction, all these things are there leading on to the ominous octet, but these two are the core pathophysiology. So deep diving into the core pathophysiology, what is there is the mitochondrial dysfunction, which can lead on to both beta cell dysfunction as well as insulin resistance, which we will be talking in the next few slides. Do you think that this mitochondrial dysfunction and diabetes is a new topic? It is not so. It has been studied for years together, probably decades together. We have research papers in the 1990s itself. So it has been studied for a long time, and now we have certain drugs that is going to address the mitochondrial dysfunction in type 2 diabetes. So going into the subject proper about mitochondria, so it is the important site for ATP production, and it is the key regulator for glucose stimulated insulin secretion in the beta cells of the pancreas. What happens when the mitochondria does not function well? It leads on to beta cell dysfunction, it increases the insulin resistance, it produces obesity, and all sorts of microvascular complications which we talk in diabetes. All these are attributed to mitochondrial dysfunction. So this is the picture you might have seen in your biochemistry textbook like Harper. So what happens actually in the mitochondria is the glucose enters into the TCA cycle and pyruvate is generated, and from the pyruvate we get this reducing agents like NADH and FADH2, and these reducing agents are going to transfer the electrons to the complex 1, 2, 3, 4, and there is going to be an electron transfer gradient that happens from 1 to 4 complexes. So while the electrons are transferred from one complex to another, some of the electrons are getting leaked into the mitochondrial plasma. So and finally, the important complex is the complex 5, where ATP is generated, and that is the energy that produces the energy source for all the cells in the human body. So what are the three functions of mitochondria? One is the production of ROS, that is the reactive oxygen species. Second one is apoptosis, and third one is ATP generation. So this reactive oxygen species is generated by the electron leak that happens within the mitochondria. What happens is when the electrons are transported, some of the electrons get leaked into the mitochondria and that are scavenged by the oxygen that is there in the cells and forms the reactive oxygen species. So whenever there is mitochondrial dysfunction, like in diabetes, what happens is there is increased generation of these reducing agents like NADH and FADH2, and so the electron transports are happening in an increased rate, so the electron leakage is also high, so the RAS production is high. So this RAS production activates the apoptosis inducing enzymes, and so apoptosis increases. That is, apoptosis of mitochondria as well as other cells increases. This happens not only in the beta cells of the pancreas, almost all the tissues of the body. So at the same time, there is decrease in production of ATP in patients with type 2 diabetes. We will discuss in detail in the next few slides. So what happens is mitochondrial dysfunction can happen because of multiple problems like mitochondrial DNA mutation and glucotoxicity in diabetes, lipotoxicity in diabetes, environmental factors like obesity, intrauterine malnutrition, pollutants, all can lead to mitochondrial dysfunction. And ultimately, this mitochondrial dysfunction leads to overproduction of this RAS, resulting in cellular injury and finally insulin deficiency and insulin resistance. So this is the one which we are going to study in detail. So the loss of glucose stimulated insulin secretion, that is how this mitochondrial dysfunction leads to insulin deficiency or beta cell dysfunction. So you can very clearly see that glucose enters into the cell, and after entering into the cell, glycolysis happens, pyruvate comes and it enters into the TCA cycle. So what happens in type 2 diabetes is there is increased supply of pyruvate into the mitochondria, more electrons are generated, more RAS is produced, so the mitochondria starts dysfunctioning. So naturally, when the mitochondria functions very well, the ATPs are generated and the ATP goes to the cellular surface and it closes the ATP sensitive potassium channel that is required for insulin secretion. So what happens after this closure of ATP sensitive potassium channel is it depolarizes the cell membrane. So this depolarization causes calcium to enter into the cell. So this calcium is required for the exocytosis of the already formed insulin that are there in the beta cells. So already formed insulins are there in the vesicles. Only when the calcium enters into the cells, this exocytosis of insulin will happen. So when there is excess glucose, like in excess uncontrolled hyperglycemia, all these processes are hampered, and there is the closure of this ATP sensitive potassium channel does not happen, and so the exocytosis of insulin is hampered. So that leads to beta cell dysfunction in patients with diabetes. So mitochondrial dysfunction leads to beta cell dysfunction. The message is very clear. So the process is this. So next one is what happens at the cellular level, peripheral cells. How this mitochondrial dysfunction leads to insulin resistance. So you can see that mitochondrial dysfunction, we have discussed about this oxidative stress, generation of RAS, and this generation of RAS in the peripheral cells activates the transcription factors like NF-kappa beta, and that NF-kappa beta or other transcription factors lead to increased secretion of pro-inflammatory genes, and this gene expression can also lead to diabetes. Apart from that, this transcription factors are going to inhibit the IRS. IRS is nothing but the insulin receptor substrate that act in the post-receptor level. So my previous speakers have described that when insulin gets attached to the cell, some post-receptor mechanisms are happening that translocates the GLUT4 to the cell membrane. So transposition of GLUT4 to the cell membrane is required for entry of glucose into the cell. So we all know that insulin binds to the insulin receptor, and something happens in the post-receptor area that helps in translocation of the GLUT receptors to the cell membrane. Only through that GLUT receptor, glucose enters into the cell. So what happens here is these transcription factors are going to inhibit this IRS so that the post-receptor mechanisms are hampered. So GLUT4 receptors are not going to the cell membrane. So glucose is not going to enter into the cell membrane, enter into the cells. So thereby increasing the insulin resistance. So we have seen two topics clearly. One is that mitochondrial dysfunction hampers the beta cell function. Second one is that mitochondrial dysfunction increases the insulin resistance. And the third one is that there is going to be increased lipotoxicity in patients with the diabetes. So there is increased diacylglycerol inside the cells. So this diacylglycerol increases the serine threonine kinase activity. So don't remember all these things. All these things are given in the biochemistry book. So it increases the serine threonine kinase activity, which later on decreases the tyrosine phosphorylase of the IRS. Here again the IRS is affected. So by due to this lipotoxicity, there is decreased tyrosine phosphorylation of the IRS, and this IRS production is reduced. Again the same thing happens, the GLUT4 translocation does not happen. So because of lipotoxicity, there is increase in mitochondrial dysfunction that again leads on to insulin resistance. So this picture, you see this half of the picture, what happens in a normal cell, whenever there is a mitochondrial damage, there is mitophagy, so that the damaged mitochondria are engulfed and there is a increase in healthy mitochondria. This is in the normal cell. Whereas in a patient with type 2 diabetes, because of glucotoxicity, lipotoxicity and all the damages that occur in the diabetic cell, this mitophagy does not happen, so that all the damaged mitochondria are accumulated. So if you see the final balance, the mitochondria that are damaged are very high in number rather than the healthy mitochondria. So these damaged mitochondria are responsible for the beta cell dysfunction and the insulin resistance. So ultimately mitochondrial dysfunction happens because of various reasons, and they lead to insulin resistance, cardiovascular disease, diabetes, obesity and all the complications of diabetes. So at the heart they are going to produce a progressive worsening of heart failure and deterioration of LV systolic function, and at the skeletal muscle it increases the exercise intolerance, weakness, fatigue, all these things, and in the kidneys they are going to cause a renal dysfunction and poor control of blood pressure. So all the problems associated with the type 2 diabetes and all the complications associated with type 2 diabetes are because of mitochondrial dysfunction. Now moving on to the drug target that addresses the mitochondrial dysfunction, we have 3 drugs. One is the metformin, second one is the penformin, which is not under use, and the third one is the imiglivin. So imiglivin is a new drug that derives its structure from metformin. See, it has a dimethyl ring and a cyclopentane ring. In addition to that, what metformin has. So this imiglivin is going to competitively inhibit the complex 1 and complex 3 activity, thereby restoring the mitochondrial function. So the enzymes within this complex are inhibited, so that what happened in the damaged mitochondria is restored. So there was increased electron transport, increased electron leakage in the damaged mitochondria, but all these things are going to be restored by the use of imiglivin. So what metformin does is that it produces a non-competitive inhibition of the enzymes present in these complex, particularly the mitochondrial glycerophosphate dehydrogenase, that is going to produce increased lactic acid. So that lactic acidosis associated with the metformin usage is not seen with imiglivin. So that is the one difference between metformin and imiglivin. What happens in the normal cell is that this we have explained earlier. The electron transport happens and the ATP generation occurs, and the new receptor that is seen is the MPTP, that is mitochondrial permeability transposition protein. So that protein increases the permeability of the mitochondria. What happens in diabetes is that we have already described, there is decreased ATP production and increased ROS production. So the imbalance between this ROS production and ATP production opens up this permeability transposition protein. So this is called as leaky mitochondria. So this mitochondria becomes leaky, and all the proteins and all the cell contents are released out of the cell and the cell dies. So this is what happens in type 2 diabetes. More increase in production of ROS, less ATP, opening up of the MPTP channel, the mitochondria and other cells die. So this is called as leaky mitochondria. So with the help of imiglivin, we are going to stop this leakage from the MPTP channels and also various effects on the complexes. So this is what happens with use of imiglivin. It increases the complex 3 activity, it restores the NADP, that is the reducing factors equilibrium, and it improves the potassium sensitive ATP channel closure, which was not there in patients with type 2 diabetes, and it increases the calcium influx so that the insulin secretion increases. So on one side, it improves the beta cell function by releasing the already secreted insulin. So it acts as an insulin secretagogue. So better insulin release in both phase of insulin secretion, both phase 1 and phase 2 is increased. So there is an improved beta cell function. In a long run, you can see that beta cell pancreatic mass increases. It increases the beta cell proliferation as well as beta cell apoptosis is suppressed with the use of imiglamin. And if you can also see that there is an improvement in the IRS activity. We have seen that in patients with the diabetes, IRS activity is suppressed because of mitochondrial dysfunction. Here it is going to improve the IRS activity. And you can see the fourth point, that is it is going to improve the translocation of the GLUT4 to the cell membrane. So more glucose can enter into the cells. So by this activity, it improves the insulin resistance. So the message is very clear. In patients with mitochondrial dysfunction, insulin secretory capacity decreases, insulin resistance improves, and with the use of imiglin, we are going to address these two problems. So it has a dual action. It improves the beta cell function and also improves the beta cell. It also improves the peripheral insulin resistance at all levels. See, you can see at liver, at skeletal muscle, at pancreas and at adipose tissue, at all places insulin sensitivity is increased with the use of imiglamin. So the final take home message is mitochondrial dysfunction causing diabetes is not a new thing. It has been studied for decades together, and the three important functions of mitochondria is ROS production, ATP generation and apoptosis. In a normal mitochondria, these things happen in an equilibrium and a cellular homeostasis is maintained. What happens in diabetes is there is increased ROS production, increased apoptosis and less ATP production, and these factors are restored by using imiglamin. And this imiglamin, I don't go deep into this imiglamin because that is beyond the scope of my topic. This imiglamin can be used in clinical practice for patients with type 2 diabetes who are not responding to metformin or who have metformin intolerance or who develop side effects for metformin. I have been using imiglamin for a long period of time with a good effect in my patients. So with this, I like to thank for your patient listening. If there are any questions,
Thank you, Dr. Magesh, for your very crisp and crystal clear presentation regarding the function of mitochondria and the target. Without knowing the function of mitochondria, it is difficult to connect mitochondria and diabetes. To concise the mitochondria, the function of mitochondria is ATP production. It plays an important role in carbohydrate and fat metabolism. So these are the reasons this mitochondria is connected with diabetes. And first, I want to ask a question to the speaker, Magesh Babu. In type 2 diabetes, we see mitochondrial dysfunction in liver and muscle. It is documented. I want to know whether it is the cause for insulin resistance or it is a consequence of insulin resistance.
See, we have discussed in my topic itself, it is a cause for insulin resistance. So mitochondrial dysfunction happens because of hyperglycemia. So this hyperglycemia increases the electron transport chain so that the leakage is high, the ROS production is high. The ultimate reason behind the damage is the increased ROS production. So this mitochondrial dysfunction is the cause for insulin resistance rather than it is the effect of insulin resistance.
So insulin resistance, mitochondrial dysfunction is the first.
Yeah.
Then it can lead. It leads to insulin resistance. Okay. Any questions from the floor?
I think the way how it is really a fantastic way you put the whole fight in the perspective. In theory, this drug is really beautiful and looks very outstanding. Even in 2024, lots of articles are coming up which are showing that not only this tackling this insulin secretion and resistance, it is also going to protect your heart, your kidney, and other things.
Yes.
But I wonder, still it is the market share is very low. And although so what is happening? If patient is coming with me, I am writing the first line drug which has been told by the guidelines, like RSSDI, AD or whatever it may be. Only Japanese guidelines
Yes.
have mentioned
Yes.
even the RSSDI guideline has not so far.
Yes, yes.
So I think the patient is checking on 4 drugs, and I am going to start insulin. The patient tells me, oh sir, I will be better you kill me, but don't give me insulin. Then I am saying this is option. So if the insulin resistance and secretion is happening that it should be, but lots of colleagues are here, they don't have very good experience if it is given in that stage, after the 3 drugs, 4 drugs. But otherwise, definitely, if our guidelines say, after a lot of research, because even all the special situations you can give, even with the kidney failure or other things.
Yes.
Ultimately, what he is asking is,
My
tell me
idea-
your experience.
See, ultimately, when a drug comes from the eastern countries, the western countries don't accept. So, for example, like pioglitazone or lobeglitazone, still not endorsed by the American Diabetes Association or the other eastern organization. So, similarly, imiglamin came from Japan. So, still it has not been recognized by the western countries. But we have a very good experience in usage of imiglamin and glitazones, which produce greater efficacy in our patients. To tell few points, like imiglamin helps in reduction of insulin dosage requirement in patients who are on very high dosage, like 100 units, 120 units. You add imiglamin, the dosage requirement comes down. So,
You are using as a first line.
no, I have not used as a first line agent, but in patients who are not responding to metformin or develop GI intolerance for metformin, we can very well replace metformin with imiglamin.
So I completely agree. As you said, there are other drugs like alpha glucosidase inhibitors. There's no mention in the Western guidelines, but still we tend to use it. Correct.
So the one more thing which has to be digested with a pinch of salt is that we don't have any cardiovascular outcome trials. Last week I talked about the same drug in a cardiologist group. They were all opposing that, no cardiovascular outcome, so we are not going to use this drug.
And
But,
also,
yeah.
and also, as per the approved label, you can only use it in patients with an EGFR above 45.
Yes.
So not 3B and below.
Yes.
But there is a difference. If you take the Japanese guideline, they clearly say that in the EGFR less than 45, you can use the 500 milligram BD. But our Indian guidelines, they have not said to that you should not use if their EGFR is less than 45.
So this is the time to wind up the session.
Thank you.
So thank you. I thank all the 3 speakers. Just, madam, you ask. Just no problem.
We can discuss later, madam. We are running short by 45 minutes. So I would like to thank the chairperson and the speakers we would go on for the next session. Thank you, madam. We will discuss later. We are running short by 45 minutes. May I request Dr. Ravindran sir to honor Priya Malini, madam. Dr. Balaji sir to honor Dr. Mahesh Babu.